Hello, everybody. Hello and welcome to today's Philips webinar, Frontline Clinical and Operational Considerations in an Eco Department during and after the COVID-19 pandemic. My name is Diego Colas from Philips Health Tech APAC, and I would like to thank you for joining and welcome all of you. I see we have participants from Australia, New Zealand, Korea. I see participants from Indonesia, from our friends from Hope Cardis. Welcome all of you also, and from all over Southeast Asia. So again, welcome, thanks for joining to this webinar, Frontline Clinical and Operational Considerations in an Eco Department during and after the COVID-19 pandemic. The learning objectives today will be around the operational and clinical considerations, the challenges to adapt to the COVID-19 crisis, as well as the priorities in imaging, the spectrum of cardiovascular manifestations in the COVID-19 pandemic, as well as the lessons learned to improve daily practice. We would love to hear from you, so please, during the presentation, type any questions that you might have in the question box that you will find in the control panel of Teams. And these questions will be brought up during the Q&A session at the end. And now I would like to introduce our speaker today. We have a very, very special guest. We have with us Dr. Teresa López-Fernández. Dr. Teresa leads the cardiac imaging unit and the Cardio-Oncology unit at La Paz University Hospital in Madrid, Spain. And as you may know, Madrid was one of the cities in Europe that was more impacted by the COVID-19 pandemic, and La Paz, one of the main hospitals in Madrid. That's why we are lucky to have such a frontline experience being shared to us today. Dr. Teresa's clinical and research focus includes mechanisms and diagnosis of cardiac complications of cancer therapies and cardiac imaging as well. She's the secretary of the European Society of Cardiology Council of Cardio-Oncology, and she's also the president of the Imaging Association of the Spanish Society of Cardiology, the coordinator of the Spanish Cardio-Oncology Working Group, and the leader of the Spanish chapter of the International Cardio-Oncology Society. So again, thank you very much, Teresa, for being with us today. And without further delay, I leave the floor to you.
The topic of my presentation is clinical and operational consideration in an eco department during and after COVID-19 pandemic. Here are my disclosures. And this is my agenda for the next minute. First of all, I want to summarize for you what is La Paz University Hospital, and to focus your attention on the big picture of COVID-19 in our hospital during the previous month. Then we are going to review some operational and clinical consideration during this pandemic, and how we organize our cardiac imaging unit during this month. And at the end, I want also to share with you some lessons that we have learned from COVID-19 pandemic. So this is La Paz University Hospital. La Paz was built in 1961 in the north area of Madrid, and is a part of the national health system in Spain. And in fact, is one of the biggest hospitals in our country, with more than 1,000 beds, 1,300 beds. And these beds are divided in 4 buildings. And we also take as part of our hospital 2 small hospitals, Hospital Carlos III and Canto Blanco, that are focused on infection diseases and also chronic diseases. And La Paz University Hospital also hosts a research health institute called IdIPAZ, IdIPAZ is an accredited health research institute that was created 10 years ago as a part of a consortium not only with La Paz, but also with Fuenlabrada Hospital and the Autonomous University, that is a school of medicine that we have in Madrid. And the background of La Paz Institute is the research is divided in different areas, being the cardiovascular area of IdIPAZ Institute, the biggest one nowadays. And also IdIPAZ is a part of the European Strategy Forum on the research infrastructures. So we generate a huge scientific production in all these different areas. As in other institutions, coronavirus completely changed the way we work at hospital, the way we work in research projects. And as you know, in less than 2 months, there is a fast spread of the virus with a high morbidity and also a high mortality that completely changed the way of organizing research and of organizing a health system to our patients. In fact, a COVID pandemic has created an unprecedented challenge in clinical research because some studies need to be stopped because patients cannot come to the hospital for follow-up visit, but at the same time, there is a huge interest in coronavirus research that increase the opportunity to build a new collaborative network and also to obtain an unprecedented fast process to start with clinical registries and with research trials. So in all this complex scenario, multidisciplinary collaboration is needed in order to try to adapt all hospital resources to be able to optimize the health of our patients. And this is our main goal. Our main goal is to prioritize and to maintain essential health services. So we need to optimize how we deliver healthcare. We need to adapt every day at the beginning of this month to a changing context and to changing needs. We need to try to reorganize and to establish safe and effective patient flow, and also to optimize our workforce because many professionals were dedicated just to COVID areas and COVID patients. So the rest of the hospital services need to adapt and to work with less human resources during a few weeks. So the really critical situation is to be able to build robust multidisciplinary teams. In our hospital, these multidisciplinary teams are led by internists and by experts in infectious diseases and pneumology, but all the specialists, we are working together in the same team in order to adapt all the hospital structure to be able to have more than 1,000 patients at the same time with COVID-19 disease. And as you know, there is a close relationship between COVID-19 and cardiovascular diseases, because we know that many patients with COVID experience cardiac problem, myocardial damage, thromboembolic events, arrhythmias, or even side effect or arrhythmic side effect derived from COVID-specific medication. But at the same time, patients with the pre-existing cardiovascular diseases have an increase in COVID-19 morbid mortality, and there are a lot of papers that reflect this close relationship between COVID and cardiovascular diseases. In fact, this is one of the latest one, patients with cardiovascular diseases who develop an increase in cardiac troponin have a much higher morbid mortality during the acute hospital phase. And this complex connection between COVID-19 and cardiovascular diseases are summarized in this excellent review from the European group. And in this image, you can say very complex interaction between the virus and cytokines and endothelial cells and immunity that at the end develop a huge pro-inflammatory stage that leads to acute coronary events or myocarditis or heart failure or even arrhythmias. Again, a new recent paper from the Manzanay group reflecting how troponin impact on the on cardiovascular morbid mortality in patients hospitalized with COVID-19 infection. And other critical question in this patient that I want to comment on because it's very important, as we are going to comment later from the imaging point of view, is the higher risk of embolic event that these patients have. And in fact, we know that patients who receive anticoagulation, especially patients that require medical ventilation who receive anticoagulation, are going to experience a higher survival probability than patients who were not under anticoagulant treatment. So it seems that there are a huge number of cardiovascular problems during this COVID infection. So patients are going to need a cardiac evaluation of the heart function, and the work of cardiac imaging units is going to be critical in order to help to make the correct clinical decision in these patients during the acute phase of the disease. But we have a great challenge at the cardiac imaging unit because the hospital structure is completely changed in less than 3 or 4 days. And of course, we prioritize dedicated COVID areas, and at the same time we try to maintain the essential health services like a clean critical care unit or cancer areas or obstetric areas or dialysis, but also imaging areas. And that's why in our case, we needed to move to another place at hospital because actually the cardiac imaging unit is in front of the biggest critical care area that was dedicated for COVID patients. So in order to be able to reduce the coronavirus transmission among patients and healthcare workers, we need to move to another area. Of course, we experience a reduce in our human and material resources because we moved to a smaller area, and we need to try to reorganize all the scheduling of the cardiac imaging in order to reduce the scan times. So we need to review the history of the patient before the echo in order to be sure what is the critical question that we need to answer with imaging techniques. And we also need to change the way we organize the cleaning times of the equipment, the waiting area for outpatients, and all the patient and all the professionals that comes in during this week to the hospital, in fact, what they need is a rapid review and reporting. So we have the advantage of having at hospital interspace cardiovascular. Interspace cardiovascular is a tool that allows us to review and to report imaging without moving our PCs from the imaging area to the new area. So we are able to connect to all the imaging information from any PC at hospital. So this helps a lot in reorganizing this new temporal cardiac imaging unit. And our first task is to try to reschedule echo exam, mainly echo exam. Of course, we also take care of cardiac CT or cardiac MRI, but is it true that the most of our activity is focused on the echo lab, and to try to minimize patient visit to the hospital in order to minimize coronavirus transmission, we decided to reschedule all the activity. And for sure, the first step is to review the appropriateness criteria for every echo study according to current guidelines. Of course, we have echo that are appropriate or maybe appropriate for certain patients, but the time to perform the echo is quite different, and we decided to reschedule elective studies and only to perform urgent exams that are going to change the treatment or are going to change medical decision in some patients. And when we decide which studies were appropriate and which studies were non-elective studies, it's a time to screen for COVID disease, and we develop a short checklist in order to screen symptoms for all patients. And if this screening do not give us enough information in a selected patient, we also have the possibility to test COVID infection. Of course, safety not only for patients but also for professionals is critical during this week. And as you know, we have several recommendations regarding how to protect professionals, how to protect patients, and also how to protect and clean equipment. Because if not, the equipment is a really important source of virus spread if we are not able to properly clean the equipment. And this recommendation comes from the European Association of Cardiovascular Imaging, and I highlight the most important recommendation is a long paper that I recommend you to read. And probably the first sentence is critical to start to work on it. Echocardiography should not routinely be performed in patients with COVID-19 disease. But because these patients are able to experience a wide range of cardiovascular manifestation, cardiac imaging and echocardiography is sometimes required, and probably as first step to try to organize a focus program is recommended in order to minimize the scan time and to prioritize more complex imaging techniques. Another critical recommendation is to use the imaging modality with the best capability to meet the request. So it's not necessary to do imaging just to do imaging, just to be more calm from the professional point of view. We need to use imaging to answer question, to answer clinical questions, and of course to postpone or even to cancel non-urgent and routine follow-up exams. This is our protocol at La Paz Hospital, and when we decide that transthoracic echo is appropriate and is non-elective, we start to work on how to do this test. For outpatient, the schedule is clear, because if the checklist is negative for COVID disease, we perform the transthoracic echo with optimal professional and patient safety protection measures. And in the case of inpatient, most of our patients during the critical weeks of the pandemic at La Paz Hospital were COVID-19 positive patient or high-risk patient. And in this special population, to organize a limited echo program is probably the best way to optimize resources. And also it's critical to dedicate equipment and proof to these patients in order to be sure that COVID-negative patients are not at risk of coronavirus transmission. And this is also the recommendation that comes from the American Society of Echo. A point-of-care ultrasound is the first line application of ultrasound recommended in COVID-positive patients, because it minimizes the need of unnecessary or unappropriated transthoracic echo. And generally, this point-of-care ultrasound must be done by the professional who is working with the patients. So this minimize or reduce the exposure to other personnel on other locations to the COVID. But we need to be sure that professionals that perform POCUS are trained professional, and of course during the pandemic weeks is quite difficult to train professional, but we have started at La Paz Hospital a few months ago a training program for intensivists and internists and doctors who are working at the emergency room. And we really understand now during this crisis how important was the work we did a few months ago, because if you have in your institution training professionals that are working in COVID areas and are able to acquire good images, it's much easier to work and much easier to minimize unnecessary tests. When to perform an echo, we need to perform echo if we suspect cardiopulmonary disease, because the clinical status of the patient deteriorates, and also we need in some patients to repeat tests to monitor changes in cardiac function. And probably the best way to homogenize the clinical practice is to work on an algorithm for imaging acquisition and storage. And this is a critical part, because if we are able to store images, these images can be reviewed by an expert in cardiac imaging, so we are able to help different professionals in order to improve the record of these images and also improve the information that these images already have, but sometimes other professionals are not able to completely understand in the clinical context of a specific patient. And we need to be sure that the results of this focused echo are well documented in patient chart, because it's the only way to improve the quality of our report. And of course, even with small equipment, we need to ensure that we clean properly the proof, and also the tablet or the mobile device, in order to avoid the virus spread. This is a proposal for a workflow algorithm in the POCUS. We are going to concentrate on the main cardiac images in order to answer critical clinical question, and at the same time we are going to be able to collaborate or to improve the pulmonary disease assessment or the fluid status assessment. And for that purpose, we built this checklist. Is a very easy checklist for critical patients in order to understand if there are or not problems at the left ventricle, the right ventricle, or pre-existing significant valvular or pericardial problems. And if any of these conditions is yes, it's time to consider the clinical benefit of limited transthoracic echo that was just focused on complete the information regarding the topic that was not well screened by the POCUS, or if we have, for example, if we have doubts regarding the function of the right ventricles or regarding the function of the left ventricle, and we need to improve some quantification of this function. When to perform POCUS, of course, it's not necessary to perform an echo in every COVID patient, and it's not necessary to perform a POCUS in every patient. And these were the main indication that we have at La Paz Hospital: patient with hemodynamic instability not related to COVID infection, patient with new or worsening heart failure symptoms with a significant increase in cardiac biomarkers, patient with ischemic chest pain in order to rule out problems at the segmental contractions, patient with abnormal cardiac finding detected by CT, like cardiac diffusion or cardiac masses. And also we use POCUS to assess the evaluation of suspected or confirmed COVID-19 lung disease, and to assess the fluid status in critical patients. This is the most common finding in COVID-19 patients. Sudden right ventricular function deterioration that was related with an embolic event. And of course, if we are working with Lumify or another pocket device, it's not possible to organize an advanced quantification of the right ventricular function, but in a patient who is admitted with COVID disease that suddenly deteriorates, and if he has no previous history of a right ventricular dysfunction, and we find a severe dilation of the red ventricle, and probably when the patient survives to COVID disease, is time to quantify strain or to quantify 3D ejection fraction of the right ventricle in order to perform a close follow-up after the patient was discharged from the hospital. And as you know, imaging is critical in patients with pulmonary embolism, but is particularly important in unstable patients, because in unstable patient, the absence of right ventricular overload exclude the possibility of pulmonary embolism and minimize the need of other tests in critical patients that are difficult to move to the scan area or to other areas in the hospital. Regarding transesophageal echo, as you know, this is a high-risk test for aerosol generating procedure, especially if we use sedation. And during the critical weeks of the pandemic, we restrict the use of TE to really high-risk patients that could benefit for an emergency procedure during a TE protocol, patient with aortic dissection or patient with valvular endocarditis that are unstable and need an urgent cardiac surgery. For the rest of imaging tests, coronary CT is a really useful test in this patient to exclude or confirm coronary artery. Cardiac MRI is more complex to do in the acute phase because most of the resources of the radiology department are focused on the lung disease related with COVID infection, but in case we suspect myocarditis, cardiac MRI may change in some patients the way we treat them. Another critical area that I want to highlight is the cardio-oncology area, because during this pandemic, cancer patients still come to the hospital for daily treatments, and we optimize the monitoring of these treatments. Of course, in this area, we increase the use of teleconsultation. We increase the use of biomarkers, but some patients still need a cardiac imaging evaluation. And what we case is to move one of our equipment to the oncologic area, that is a clean area, in order to minimize the visit to restrict the number of times the patient come to the hospital. We decided to move our equipment to the oncologic area. And there are many documents, very interesting documents, focused on how to manage cancer patients and cardio-oncology during the pandemic. We have no time to comment on this, but we can discuss after the talk. And if you are interested in this topic, I recommend you to follow us in this virtual Cardio-Oncology Summit that was going to be held in October 1st with the collaboration of the International Society of Cardio-Oncology and the Spanish Society of Cardio. And to finish the talk, I want to explain you how we started to reintroduce a standard work at Cardiac Imaging Lab. Of course, each institution needs to appropriate timing to open doors, and it's necessary to continue to implement appropriate protective measures post-critical phase of the COVID pandemic, and to decide locally which patients are going to benefit for COVID testing before cardiac imaging exams were performed. In our case, for standard transthoracic echo, we do not perform COVID testing, but if we need to perform a transesophageal echo under sedation or in patients that are going to potentially experience or need other procedures after esophageal echo, is mandatory to confirm the immunology situation regarding COVID in order to continue to separate cleaned and COVID areas at hospital, just in case the patient needs to be admitted. Another critical problem is what to do with all the exams that were postponed during the crisis, and we needed to allocate a priority in order to reschedule all these exams. And we decide as high priority patient with active or recent change in cardiovascular symptoms, patient with a recent procedure that requires an urgent follow-up, patient who need echo prior to therapy, and cancer patient who are treated with high-risk cardiotoxic drugs that needs to continue monitoring for therapy. Medium priority was assigned to asymptomatic patient with chronic cardiac diseases that requires monitoring for progression, and also patients under other therapies that requires monitoring or echo prior to non-urgent therapy. And standard follow-up for chronic condition are now a low priority test, and probably we are going to change the way to manage this patient at cardiac imaging unit, because we need also to focus probably on new echo criteria for patients who suffer a COVID disease. As you know, these patients have a high risk of pulmonary embolism. They commonly develop atypical chest pain or sinus tachycardia, and we really don't know if they are going to develop or not chronic pulmonary hypertension or post-myocarditis, permanent left ventricular dysfunction. So we need to develop with the infection department and with the pneumologist a dedicated protocol to try to understand what happened in the post-COVID phase. And for that purpose, I think that advanced imaging tools like strain or 3D echo are going to help us a lot in understanding this new cardiovascular problem. Of course, the maintenance phase after the escalation is probably more difficult, because when we need to focus on protect and on reassign resources, we know that we are able to do that task, but now we need to change the way to work at hospital in order to be prepared for potential new pandemic, and we need to develop a long-term sustainable model for provision of care that needs to be permanent in order to improve our capacity to react for a potential new pandemic. And for that purpose, I think that we need to increase the use of technology to serve cancer, to serve patients' care in the three main pillars that are the reason to exist of the hospital and of the healthcare. That is the clinical care, the research, and the health promotion. We need to build robust teamwork. We need to organize local telemedicine protocol, and to imagine which is the best strategy for building a permanent protective measure for patient and professional and new tools to assess cardiovascular risk and infection risk in all our patients before they visit the hospital. We have a great opportunity to establish a COVID-19 collaborative network, and what we need to be sure from the Imagine point of view is that it's time to reorganize the criteria for imaging test. Is not time to ask for a lot of imaging tests to a lot of patients. We need to select which patient is going to benefit from one specific test and to minimize the number of repetition and to minimize the number of tests that do not answer our critical clinical question. And the best way to organize all this information is to be able to have all this information together in the to review the imaging history of each patient before to decide if the patient needs a new imaging exam, because sometimes is it possible to answer a clinical question just reviewing past imaging records of the patients. Thank you very much for your attention.
Thank you very much, Dr. Teresa, for sharing what we are sure it was a very hard and painful experience, but as we have seen, also an experience full of learnings. Let's start now. For that, remember that you can type your questions in the chat box that you will find in the control panel. And I see that we have some questions here already. I see that there is one regarding cardio-oncology. Could you add more details on the use of advanced quantification in your cardio-oncology echo studies?
Sure, thank you, Diego. This is a great question because, in fact, when we scan a cancer patient, what we need is to give an advice to the oncologist regarding if it is safe or not to continue cancer therapy, or if we need or not to implement cardioprotective measures. And for that, we need to try to be precise in our quantification of cardiac function, and most important, not only precise, but also reproducible. So in this scenario, the use of strain and 3D echo help us a lot in order to avoid misinterpretation of cardiac function that sometimes we have if we only use a standard 2D ejection fraction. It is true that during this pandemic, one of the main recommendations from all the scientific societies is to try to minimize scan times. But when using our standards tool, dynamic heart model, and auto strain, in fact, the scanning time is very short, and we perform all the quantification after the patient leaves the imaging lab. So there is no rule for excess of virus spread or excess of time scan. So we think that there are really useful tools in our daily practice, even during this critical moment at the Echo Lab.
Thank you. I have another one here. It's a long one. There is a huge need to improve communication between multidisciplinary teams or between point-of-care ultrasound users and experts in cardiac imaging. What do you think is the role of IT systems to help enhance this communication?
So one of the main problems that we have had when we start teaching non-cardiologists in order to be able to obtain good imaging views is that we need to review what they did, because if not, yes, speaking is quite difficult to improve daily practice and also to improve continuous medical education. So probably the best way, or what we try to do, is to store all the images in the same system. So if one professional that is not an image expert perform POCUS or even a standard echo, and we are able to review these images, we minimize the need for repeating echo, and also we are able to give other professionals a good feedback about how to improve next echo or how to interpret images that are already recorded and are not well interpreted by other professionals. So it's a critical tool for trying to implement an education and learning and also a clinical program to connect all the services through these ET tools.
Thank you, Dr. Teresa. We are starting to have a lot of questions. Good afternoon. This is Dr. Bobby Pratama. Would like to ask which patients can be postponed for cardiac imaging examination during this pandemic, and how to select the appropriate patients.
So this is a really good question, and it's not easy to answer because it takes a long time to decide what to do, because in fact at the cardiac imaging lab we are not doctor in charge of these patients, but we organized a team, a group of doctors from the imaging lab that were dedicated to review every patient clinical history in order to understand if the request echo is a standard or routine follow-up echo that for sure is going to be postponed, or if the echo is aimed to answer critical clinical question that cannot be postponed. And sometimes if a professional asks for an echo, but we thought that is it possible to answer the clinical question using other imaging technique, we reschedule the echo for a CT or an stress test or whatever. So I think that there are not universal rules. It depends on the hospital you work, but for sure it's very, very important to try not to focus strictly on the imaging, but on the big picture of the patients and to review clinical reports.
Thank you, Dr. Teresa. We have one question from Melbourne saying, I am curious if you have noticed any change or if you are aware of any relevant local research regarding the ineffectivity or prevalence of COVID-19 through community transmission with seasonal change. For instance, if with warm and humid summer versus colder and drier winter. Many thanks for the great webinar.
So this is also an interesting topic, but I think that from now we do not have the right answer for this, because at least in Spain we started in winter, and of course after a 3 months lockdown the virus spread decreases and summer arrives, but we are not able to be sure that it's because of summer or because of the lockdown or because of both. So we need to wait to have the right answer to this question for sure.
Makes sense. One more question. How the pathophysiology of COVID-19 can induce cardiovascular disease?
This is another great question, quite difficult to answer, because the viral invasion damage different different mechanism. Of course, it damages endothelial cells, so endothelial cell damage may induce a prothrombotic situation and leads to cardiac infarction. And in fact, one of the main problems we have had is that patients try to minimize heart attack symptoms because they were afraid to go to the hospital, and we have had some problems with patients that are delayed in asking for medical assistance. Of course, all the immunity that is activated during the infection induces a huge cytokine storm and a huge pro-inflammatory stage that may lead to myocarditis, heart failure, cardiac arrhythmias. So I think that different pathophysiological mechanisms work at the same time in order to increase the risk of cardiovascular diseases and probably to increase the thromboembolic risk. That is one of the main problems we have had with these patients. And of course, patients with pre-existing cardiovascular diseases are prone to develop all these side effects.
Thank you. Maybe we are going to ask the last questions now for the interest of time. But there is a question here that says, I would like to ask Dr. Teresa, can COVID-19 infect myocardium like Staphylococcus in myocarditis?
Not sure what is the objective of the question, but in fact, we do not found an increase in the standard endocarditis, for example, because the main symptoms related with Staphylococcus at the heart was infectious endocarditis, and we didn't find an increase in the prevalence of this problem in our institution. And in fact, I think that there are not reports published on this topic. Of course, myocarditis is one of the main clinical manifestations of COVID disease, but probably is most related with the inflammatory storm that with direct damage of the virus on myocardial cells.
Okay, one last question, okay? One last question and we let you go. Hello, Dr. Teresa, thank you for your excellent presentation. I would like to ask your thoughts on the early days of the pandemic, when the cases in Spain, particularly Madrid, were rising exponentially. What would you think would need to be improved in order to prepare health facilities for future pandemics?
Wow, this is a really complex question, but of course, this is the first time we live one situation like this, so it's difficult to be prepared for that, and probably what we need to learn is that we do not. It's dangerous to minimize the impact of new infections on the global health system, and probably from the beginning we were not able to really understand the dimensions of the problem. So the first reason is not to minimize what we are not able to control or what we don't know, and try to implement important professional and patient protective measures in order to be more effective in the disease control.
Thank you. With that, I would like to ask for your help. We really need your feedback. So please take a couple of minutes to fill in our feedback form. For that, you can scan this video code, or you will also find the link to the feedback form in the chat box. And with that, also, I would like to say a very big thank you to our speaker today, to Dr. Teresa. Thank you very much for sharing all this experience with us. We know that you have to go now to Hospital La Paz to work. It is 8 a.m. in Madrid, if I'm not wrong, and hopefully things keep getting better and better there.
Thank you very much, Diego, for inviting me. It's a great pleasure to be with you here this morning.
Thank you. And thank you all the participants that joined us today. I hope you enjoyed and found the session fruitful. Thank you again. I hope to see you in the next Philips webinar. Goodbye.